Welcome to Physician Focus. I'm Dr. Bruce Carlin. Infectious diseases have plagued humans since the beginning of time, and the arrival of a new contagion brings uncertainty, confusion, and the race for a vaccine. The experiences of severe acute respiratory syndrome in 2003, H1N1 bird flu in 2009, Ebola in 2014, and now the Zika virus in 2016 are the most recent example of threats targeting the public health. Groups such as the U.S. Centers for Disease Control and the World Health Organization rush to address these threats, and the media are quick to label them epidemics, raising fears on the part of the public. But are these fears realistic? Has media overreaction become the norm in reporting on infectious disease? And just how should the public react to these outbreaks? These are some of the questions we'll examine in this edition of Physician Focus with Dr. Stephen Hatch. Dr. Hatch is an infectious disease specialist at UMass Memorial Medical Center in Worcester and an assistant professor in the Division of Infectious Disease at UMass Medical School. In 2014, he spent 5 weeks in Liberia with the International Medical Corps, treating patients stricken with Ebola, subsequently returning multiple times to that country to treat patients. He is the author of the just published book, Snowball in a Blizzard, a physician's note on uncertainty in medicine. Welcome, Dr. Hatch.
Thanks for having me.
Well, this all came about because you gave a superb lecture at St. Vincent Hospital. And the thing that struck me at that lecture was a comment that you made. And that was the point where you said you felt more comfortable suited up in 100-degree heat and 100% humidity, millimeters away from patients infected with Ebola, giving them a back rub or whatever, than you did on returning to the United States. And I thought that that was an interesting comment as to how much the fear-mongering had blown this out of proportion, and wondered if you could speak to that to start this discussion off.
Sure. Yeah, the comment that I was making during the talk involved a question that a reporter was asking me from the United States, and I had not yet returned to the US. And this was right after Craig Spencer, the doctor in New York, had come down with Ebola, which he had acquired during his trip in Sierra Leone. And we were watching from our laptops in a remote hillside in Liberia, we were watching paranoia really sweep the countryside of the United States, and I knew I would be coming home in about a week and a half. And I knew exactly what my role was in Liberia. The patients knew my role, my fellow workers knew my role, and everybody went about their business normally. What happened when what I was concerned about in terms of going home was that the fear that people had about Ebola, which was easily visible just from reading the news stories on the internet, was going to then apply to me, and that I was going to become an object of derision, possibly violence. I wasn't sure what awaited me when I came home. And I think largely my experience when I did come home during the period where I was in active observation, some states did observation, other states did quarantines, really was a very anxiety-provoking time. And it really did prove to me that you can get a very warped perception based on what media provides in terms of information and how it chooses to couch the information, so that instead of lowering anxieties among people, that you can actually raise those anxieties.
Well, let's get some context. So how bad was Ebola actually in the United States? Well, you know, how many people died? How bad was the infection? We certainly made the headlines. It was on the cover of Time and
right.
So forth.
And the director of the Centers for Disease Control, Thomas Frieden, had said in a press conference for people to calm down a little bit, that it was actually hard to transmit the virus. And he had been actually taken to task by a lot of people in the media who felt that he was downplaying the fears, he was being cavalier. And when you actually take a look at what happened in the United States, there was a man in Dallas who was a Liberian. His name was Thomas Eric Duncan. He had returned from Liberia in mid-September of 2014. And a couple of days after he arrived in Dallas, he began to feel ill. After a couple of days, he went to the emergency room at Dallas Presbyterian Hospital, where after waiting around for about an hour, hour and a half, he was evaluated by the medical staff. He had been sitting out in the open in front of dozens of people. He went through an evaluation where they did not get the triggers that might have isolated him and identified him as a potential Ebola case and do the proper testing. So he was given a diagnosis of a relatively common condition and sent home. He went back home, stayed with his girlfriend and his 5 children, I believe, in a very small apartment. A couple of days later, as his illness worsened, he called 911 and the emergency technicians took him back. He was then properly identified, isolated, moved around. At the end of all of that, he died on October 8th, about 2 weeks later. And at the end of all of that, he'd exposed upwards of nearly 200 people at close range. And the total number of people that he actually managed to infect was 2. And there wasn't a lot of news media devoted to explaining that story.
And that was essentially what Dr. Frieden had said.
Exactly.
Yeah.
And so what you get was this very asymmetric response in the news media where Dr. Frieden's press coverage was sort of treated with a great deal of skepticism, and yet when it was really proven that his advice was sound, very few people were actually sort of either owning up themselves and saying, I got this wrong, or saying, Dr. Frieden was right.
So how do we put that into a context of what's happening with the media? Now, are they wrong to report it? How should they have reacted? What would have been the good story, and how should we have handled all this?
To do a full biopsy on the media response to Ebola is a much longer topic and something that I would want to have studied a lot. But what I think there could have been is a couple of simple take-home points that you did see in other media outlets around the world. One thing, for instance, in the coverage of the BBC from Great Britain, was at the end of every news story they did online, they had a series of bullet points about the virus. This is how many people are infected in West Africa. The virus cannot be transmitted by air, which was something that had to get repeated over and over and over again, and yet it was almost like a zombie idea. You just couldn't kill it in the United States. And
the zombie idea being that it could be.
That it could be, and there was an enormous amount of coverage devoted to whether or not this could be an airborne virus. And the fact that most animals, besides primates, chimpanzees, gorillas can get it, but other common house pets in the United States, cats and dogs, can't get it. There was a lot of coverage devoted to whether or not one of the nurses who Thomas Eric Duncan had infected during the course of his illness, she had a spaniel. And there was a whole enormous amount of media coverage that was devoted to this dog, even though there was no evidence whatsoever that dogs could get it. And yet over and over and over again, there were stories really asking this question repeatedly, even though the answer was no all the time. And when you have that many stories devoted to a topic for which there's pretty clear evidence that there's no evidence, there's pretty clear evidence that there's no transmission, you have to wonder why do we keep zeroing in and doubling back on these questions all the time? And the conclusion I come away with is that people were really gripped in the vortex of fear, and there were particular news media outlets that really fed this.
I wonder, you headed right over there. This is your area of interest, these hemorrhagic fevers, and you went right into the vortex without any fear, or was there fear? What was the special knowledge that you had that said, look, I can go and I can learn something from this?
I had been to Liberia before the outbreak occurred, and I knew people there. And as an infectious disease doctor, my job in life is to treat patients with infections. And so once I saw that the outbreak was taking place, especially among people that I knew and cared for, I felt that I had an obligation to go. I also felt that I could bring some perspective to the care of patients with Ebola that some of the other people who also brought their own areas of expertise, my expertise could complement theirs. Most of the people who worked in places like the Ebola treatment units run by Doctors Without Borders, International Medical Corps, the International Rescue Committee, there are a variety of other organizations that set up these ETUs, Ebola treatment units, that they were a lot of them were emergency physicians. And as an infectious disease doctor, I thought that I had some skills that could complement that.
So I find it fascinating. You can't tell me enough about these Ebola treatment units, but you're right in the middle of the storm there, and treating these patients and setting up the units weren't they were state of the art, but they were just tents, and it was amazing that you were able to provide such care and such primitive tools that you have.
Yeah, I mean, actually, that's another point about media coverage, is that particularly when you see the coverage of Ebola research in the United States, you always see biosafety level 4 facilities where...
biosafety level 4.
Oh, I'm sorry, very technical talk here. But I think actually, even without fully explaining the term, I think viewers will immediately unpack. They'll know something, that a biosafety level 4 is really where the people walk around in the spacesuits in these very, very high-tech facilities where the rooms are sealed. We didn't have that, and yet we were able to provide care that I think was actually pretty good. And obviously, we wanted to have a bigger impact on the mortality, but you, like other things in resource-poor settings, if you have a good game plan for how you want to deliver medicine, you can deliver pretty good medicine. And the visual images that you would see during the coverage of the outbreak reinforced some underlying narratives about how things were out of control, as opposed to that we had a plan in place and we're getting things under control.
So that was the expertise that the emergency guys brought to the table, showing how to triage and to sequester people,
as well as the mobilization of the African communities themselves. I think they probably played the biggest role of all. Is we got people to change their behaviors, and we got them to buy into the importance of changing their behavior to slow the spread of the outbreak. And what we saw in the United States was actually, if not the polar opposite, something that really careened in a very different direction, where there were thousands of actual cases in West Africa, and people moderating their behaviors so as to minimize the spread of the disease without the collapse of the structure of society. And yet what you saw in the United States was a hugely disproportionate response to the actual number of cases that were being transmitted, because there were only 2 cases of Ebola that occurred in the United States.
2. You just say 2. It's astounding when you say the stimulus response is so out of proportion.
Yeah.
So having said that, how should we respond to some of the more current events? What should we be thinking about something like Zika that's being touted as the next important thing to spend time on?
Yeah, I mean, Zika for me has been somewhat distressing to see, again, a response that seems to be far out of proportion to what the actual threat is. And when you talk to people about Zika who are not specialists, and you ask them, well, what really is the danger? And people are very vague about it. They know that Zika is menacing, but they don't know precisely what the menace is. Zika's actual threat appears to be that it can cause a birth defect known as microcephaly, where the child is born with a very small head. It happens during the neurological development of the fetus during pregnancy, which means that from what we know scientifically right now, the people who are most at risk are pregnant women. Which means that everybody who is not a pregnant woman, or possibly some men who may be with women who can get pregnant, but aside from those two demographics, Zika is really not a terrible virus to anybody else. A Zika infection causes a mild illness. And for the most part, it's not an exceptionally dangerous virus. There is an association with this birth defect called microcephaly, and even in Brazil, where there are studies that are ongoing right now, the rate appears to be about 1 in 1,000 live births. By contrast, in the United States right now, if you want to take a look at a devastating illness that occurs in newborn infants that has about a 1 in 1,000 live birth incidence, take a look at fetal alcohol syndrome, which occurs when pregnant mothers drink very, very heavily during pregnancy. And those children end up actually having neurologic complications as severe.
Throughout life, too.
That's correct, as microcephaly. And yet you're not hearing a news story every single day and an army of people working for the CDC devoted to fetal alcohol syndrome. And so to me, as I'm watching this coverage, the question is, well, why aren't you? And I think some of this is this reaction to viruses. And I think at some level, Zika as a phenomenon in the public discourse was really primed by the West African Ebola outbreak, because there was so much anxiety over it that all of the public health authorities did not want to be perceived as being asleep at the wheel when Zika really came into the public eye. They wanted to make sure that they were doing everything possible to protect the public health.
You were talking also about some of the news coverage concerning the mosquitoes, and I thought that was another interesting example of a disproportionate fear mongering in the face of a smaller problem. And could you?
So it relates to what transmits the Zika virus. So Zika is a virus that is transmitted by a mosquito called Aedes aegypti. And there is a related species of mosquito called Aedes albopictus. And it turns out that Aedes aegypti in the United States really occupies the southernmost, hottest parts of the American map. So the border of Texas and Mexico, southern Florida. Albopictus ranges throughout the southern Midwest on the eastern side of the Mississippi and goes really all the way up into Maine. And there have been a couple of stories that have come out saying, so Zika might be spread in this relative species, and from there, people have sort of gone in a chain, right? They've gone in a chain of conclusion so that it gets people very worked up, even though none of this has ever been proven. And people are making guesses on the potential spread of the Zika virus when I think the evidence that would support those fears are very, very thin.
What I find interesting is that the news story will be that here's this mosquito that can transmit it, maybe, and yet nobody's seen that. And I have a feeling that in the background, our CDC and our public health departments are testing these things on a level that Liberia never saw. And the title of your book, A Snowball in a Blizzard, says we have a lot less to fear because we've got governmental structures and public health infrastructure that really does protect us. And one of the other points that you made in your lecture had to do with saying that when you devoted all this energy to Ebola, that you were detracting from other things happening. Can you just go over those points that you made?
There's a lot in that question. My first reaction as you were talking about it was to actually, what made me think about it was the amount of press coverage devoted to the dog story about this dog, and that by asking the question itself, you get people focused on something that really that wasn't necessary to be in the public eye in the first place. In terms of the broader question, I think what my concern about with Ebola is, and Zika as well, and as you noted in your introduction, other scares that have come along, SARS, the H1N1 is a little bit different because I think that was really a potential genuine threat, and we did not know how serious it would be at the time. I think anytime you have a flu strain that could be deadly, I think caution is appropriate. But yet there's always sort of a virus du jour. In addition to that, there was one a couple of years ago called the Middle Eastern Respiratory Syndrome, which was called MERS. And it never quite got the popularity of either Zika or Ebola, but it was in the news last year at this time. And when people get worked up over these viruses, several of which can be relatively trivial threats, what happens is you get this difference in risk perception. And so people are, during the outbreak, were very, very scared in the United States. Even in Dallas, where there were actual cases of Ebola, there were plenty of people in Dallas who were incredibly anxious about acquiring the Ebola virus, and yet the double cheeseburger that they ate that morning was actually much more dangerous to them in the long run, or for that matter, the car that they got into, which as a statistical matter, going from point A to point B in any major metropolitan city, you know that there are a certain number of accidents that are going to happen, some of which are going to be quite serious. In a nation of 300 million people, there were 2 Ebola infections. A lot of people died during that time from heart attacks. A lot of people died from lung cancer, which are due to the effects of smoking. A lot of people died from gunshots. And a lot of people died from heart attacks. And yet we get this very dramatic warping of our perception of what actually represents a real harm to us in life. And I think that's actually quite sad, because you can do something about modifying your lifestyle decisions, but people don't really, I think, get that message as purely and in as undistilled a manner as they could, and everybody gets focused on what are relatively trivial threats.
So getting back to Liberia and talking about what happened when they focused on Ebola, you made the comment in your lecture that because of that, the focus was away from measles vaccines and so forth, and that actually more people might have been hurt by that than were helped by the focus on Ebola.
Yeah. To me, the point I was making is one of the real ironies in the discourse around viruses is that there is a group in the United States that's very resistant to the idea that vaccines of any kind, but in particular the measles vaccine, which is part of a group of vaccines, measles, mumps, rubella, so that they all get put together in the modern vaccine. And there are people who think that that increases the risk of a variety of maladies. Most commonly, they talk about autism. And what happened at the time is in Liberia, the entire health system shut down. And as a consequence, nobody could get vaccinated for measles. And a couple of researchers at Princeton took a look at this and made estimates based on how deadly measles is, which is not very deadly, but it spreads like wildfire. And so what they discovered was, in a place where you shut down the healthcare system and routine vaccinations in an area of 22 million people, you could actually end up with as many people dying from measles as the number of people who had actually died from Ebola at that point. And I think, again, it showed in some ways that measles is really sort of the mirror image of Ebola, that Ebola is very deadly to a person if they would get it. But really, when you looked at the 22 million people in the 3 affected countries, it turned out to be, a horrible epidemic of unprecedented proportions. But on the other hand, measles can be deadly in large groups, even if it's not necessarily deadly to a person, and that is based on the transmission dynamics.
Steve, I imagine that we could go on for another hour with your wealth of knowledge and personal experience is second to none, and you've been an absolutely fabulous guest. I want to thank you for coming here to Physician Focus. And maybe we can get you back some other time to talk about some of these issues.
Great, thanks for having me.
For more information on infectious diseases, visit our homepage at physicianfocus.org. I'm Dr. Bruce Carlin. Thank you for watching.
I'm Dr. Dennis Dimitri.
I'm Dr. Monica Burrell.
Prescription drugs are valuable medicines, and when taken under a doctor's supervision, provide effective pain relief for many conditions.
But the abuse of these powerful drugs has become a serious public health problem in Massachusetts and across the country, resulting in the needless deaths of thousands of people.
If you are prescribed opioids or pain medication, talk with your doctor about the risks and benefits of the medicines and explore different ways to treat your pain.
The safe use of prescription drugs comes when physicians and patients work together to promote healing and good health.
Medicines cure, heal, and relieve pain. Use them carefully, store them securely, and dispose of them properly when no longer needed.
What you do can make a difference. For more information, visit the websites of the Massachusetts Department of Public Health or the Massachusetts Medical Society.
I'm Dr. Frank McMillan.
And I'm Dr. Raj Devarajan.
Colorectal cancer is the second leading cause of cancer-related death in the United States, claiming more than 50,000 lives each year.
The cancer occurs in the colon and rectum, parts of the large intestine, and is caused by growths called polyps that can turn into cancer.
Screening for colorectal cancer saves lives, but 23 million American adults, about 1 in 3, don't get screened as recommended.
Colorectal cancer affects men and women, and the risk rises with age and a family history of the disease. If you're over 50 or have a family history of the disease, early screening is recommended.
Screening can reduce the risk of colorectal colorectal cancer by up to 90% by finding and removing the growths before they turn into cancer.
For more information on colorectal cancer and the different screening tests available, visit the American College of Gastroenterology.